Good morning, good afternoon, good evening from wherever you're joining us from. A warm welcome on behalf of the Boost team to our Bright Spots webinar featuring the story Zero Dose No More. Before we get started, I just want to go over a few housekeeping slides. Next slide. So we're using a Zoom meeting format today. So we ask that you remain muted to minimize any background noise. You can always raise your hand during the presentation to speak, or you can also use the chat box to submit questions, make a comment, or respond to other participants. Now would be a great time, and I see some of you have already been doing this, to tell us your name and where you're joining us from in the chat box. Next slide. So for those who are joining us for the first time, the Boost community is a diverse network of more than 1,500 immunization professionals from over 125 countries. Through our online platform, boostcommunity.org, we offer opportunities for our community to connect with peers, strengthen leadership and advocacy skills, and grow in their careers. And just a quick note that we'll be storing today's session recording and slides in the resource library of the Boost Bright Spots Learning Group on the platform. So we do encourage you to sign up and join that learning group. Next slide. So for those who are new to this Bright Spots series, Bright Spots are stories that shine a light on the work that is happening on the ground and inspire immunization professionals everywhere to learn, adapt, and take action in their own communities. From engaging with religious leaders in the community to improving supply chain delivery to reach the last mile, there's innovation occurring at all levels of the immunization system. In the second round of Bright Spots, which we announced last month, includes 10 stories from 6 countries. Over the next couple months, we'll be slowly releasing these stories onto the Bright Spots microsite, which is brightspots.boostcommunity.org. And just yesterday, we released the next round of stories. So right now we have 6 stories that are live on the Boost microsite, featuring the second round of Bright Spots. So through this live series, Boost offers an opportunity for our members to hear directly from our Bright Spot story submitters to better understand their challenger program and how they achieved this success. So with that, next slide, I'd like to introduce our speakers for today's session. So we have Huma Khawar and her colleagues, Lubna and Imran. So just a quick background. So Huma has 30 years of well-rounded media experience working as an independent journalist, contributing op-eds, articles, and features in major newspapers and periodicals with special emphasis on women and children health. Since 2006, Huma has been working with Pakistan's expanded program on immunization that aims to vaccinate children aged 0 to 15 months against 10 vaccine-preventable diseases and pregnant women. Presently, she's working with the Civil Society Human and Institutional Development Program, CHIP, and she's coordinating between government and civil society organizations on immunization and women's health in Pakistan. Her colleague Lubna Hashmat has worked extensively for improving maternal child health and immunization coverage in Pakistan. She's worked with more than 200 CSOs in Pakistan, and partially in Afghanistan for their capacity building and extending technical support in setting strategic directions, developing policy papers, and context-specific community development programs. And then finally, we have Imran Ahmed, who's worked in CHIP's program implementation and management section since November 2005. He's been a key contributor towards community engagement, both in urban and rural settings, aimed at improving immunization coverage. Imran was also part of the team that mapped urban slums in 10 larger cities of Pakistan, more recently in 2019. So with that, I'm going to hand it over to Huma, who's going to be leading today's presentation. Over to you, Huma.
A big thank you to the Boost team for letting us share our story. The story of Zero Dose No More is about a slum community in the central city of Lahore, which is in Punjab in Pakistan. And we talk about how this initiative actually, took the zero dose to a very lower level and how the under-immunized were immunized. Next slide, please. So the purpose was actually to strengthen the demand for immunization through improving knowledge and practices of caregivers towards childhood immunization and to improve antigen-wise coverage rates for under 2 years children, though through coordinated working with government vaccinators for effective vaccine service delivery. The location was 12 slums of Union Council 110 of Lahore city. Approximate population was 9,319. Initially, the total number of under 2 years children were under 2 year children was like 696. But as the new settlers came in and newborns increased, the total number that at the end of the initiative were 1,150. The time frame that we calculate was from September 2018 to December 2019. It's like about 16 months initiative. Next slide, please. Disease outbreak was actually the core problem. When the data came to us, we realized that 36% of children had not received any antigens throughout this period, and almost 39% had not received a complete vaccination schedule, which is offered by the expanded program of immunization for 1-year-olds. So in all, there were like 70% children who were either 0 dose or under immunized or partially immunized. Next slide, please. So the most significant contribution of this initiative is that the 0 dose was reduced from 36% to 4%. And the dropout, which we calculate as the under-immunized children for 1-year-old who have not received measles 1, reduced from 39% to 1% to 2%. Next slide, please. Well, the barriers. Of course, there were many barriers. Some of the barriers in the initiative were common, like working in any community. But some barriers were very, very specific, which we also learned were working in the slum community. High level of fear and myths, which is common in most of the communities, was there against childhood immunization amongst caregivers. There was low literacy level of caregivers. Caregivers were afraid of evacuation, hence unwilling to interact with non-locals. This was very particular for these tented settlers, settled in the slums. High flow of incoming migration, which was a rapid urbanization of the area. Economically weak, hence ensuring food security during daytime was more important to them to tackle rather than looking at other other issues like invisible children. This was particularly because these were daily wagers who were looking for work on daily basis, and the children were left home to care for themselves with their grandparents or somebody elder in the family. Weak system, I mean, you can't say weak system, we can call it gaps in government system for recording newborns and new settlers. And illegal settlements not eligible for public health services was also a major problem because these were slums and these were not recorded in the government area and in the government records. Next. So how did we overcome the barriers? For fears of myths against vaccination, hiring or contracting community resource persons who were from the community, they were trusted in the community, they held frequent house-to-house visits and were able to reduce fears and myths of caregivers. Specific counseling of AEFI with support of Panadol. Panadol syrup is used for reducing fever and temperature amongst children. And most of the AEFI cases which they considered, the caregivers considered, was actually temperature and fever of the child. So many caregivers that we spoke to they said that since the penta causes temperature in children, it is very difficult to take the child to any health facility the following day. So giving them Panadol along with the first dose of penta really worked well. Engagement of local influentials and religious leaders was also very helpful. Another something new was actually the healthy baby shows that was organized in the area. And this was an incentive for completing vaccination doses. It was like a competition for amongst caregivers to see that how many children or had completed their full vaccination, so that some kind of an encouragement is created amongst the communities. The low literacy level, for low literacy level, we try to use pictorial, illustrated, supported material, which were, showed as shared with caregivers, and in the illustration with pictures and with colorful caricatures, caregivers were made to understand the importance of immunization on one-on-one sessions amongst, these were given by community resource persons. Fear of evacuation was, of course, a big issue in these slum areas. Slum health committees comprised influential individuals and caregivers, facilitated outreach sessions, outreach vaccinations. They made efforts for legalization of their residential areas as well. Economically weak employers of these settlers or caregivers, like, most of the caregivers were either working as maids or drivers, and the contacting their employers worked well because their employees were requested to influence them or request them to go for childhood immunization. So it was not just the CRPs or the community resource persons trying to convince the community. It was also coming from the other way, from the other end, where these people were working. Flexible timings proved to be very, very effective for outreach vaccination services, according to the availability of family decision makers. Then migration, of course, continued, and weekly update on new settlers and child registration was actually done by the CRPs, because there was a constant flow of immigrants coming in. Not eligible for public health services, evidence-based target setting for vaccination, especially in areas which were not included in earlier targets, and then intensive social mobilization during outreach sessions, so that when the vaccination session is held, the community resource person made sure that the eligible children gather together, and they ensure that when the vaccinator is sitting in the outreach session, they are vaccinated. Facilitation for transport to access health facilities when needed. These was done by the Rickshaw Association, who were able to mobilize, to take the caregivers to the health facility as and when required, so that, their immunization, they can take their children for immunization without any burden of checking out on a transport. Next. The lessons. Comprehension of local dynamics helps tailoring community engagement measures according to the local norms and culture. It also helps in setting up realistic targets for microplans and outreach vaccination. Effective interpersonal communication skills, which our community resource persons were equipped with, really helps amongst caregivers. Activities focusing peer-to-peer support, such as healthy baby showers, which I just mentioned, encourages mother to complete vaccination. Convincing just the caregiver is insufficient. It is important to convince the decision maker of the house, because here the decision maker of the house were not always the mother. It was either the grandmother who was left with the children, and the mother was gone for work the whole day. And then the fear of that grandmother was actually that if the child develops fever, I will be left to take care of the child. So there's no point of getting the child vaccinated. And close coordination with implementing partners, especially with the Department of Health and EPI, really helped in sharing challenges and suggestions and suggesting viable solutions. It also helps in creating mutual accountability. Evidence-based microplanning for outreach vaccination that is based on realistic number of children and their actual status to meet the targets. Location of outreach vaccination according to the concentration of zero dose in dropout children improves. The access of caregivers for vaccination of their children, leaving no excuse. Indigenous points for organizing awareness raising sessions such as local tea stores, barber shops, rickshaw terminals also helps. Next, please. So these are the graphs which shows that how the zero dose from 39% were reduced to 4%. And in the second cohort, they were reduced from 18% from the baseline to 4% after the demand generation and the social mobilization. I think I will end here and make the floor open for my colleagues to answer if there is any questions coming in. Over to you, MJ. Liz.
Great, thanks so much, Huma. And as she noted, we're definitely please either raise your hand or submit your questions through the chat box. I think we did have a question from Dr. Rajat around Panadol and if it was in syrup form. Did you catch that one, Huma?
I'm sorry, actually. Please come again.
We had a question from our colleague, Dr. Rajat, who had asked if Panadol is in syrup form.
Panadol is?
Yeah, in syrup form.
Sorry, come again?
Maybe, I don't know.
Yes, it is in syrup form.
Okay.
Yeah, it's in syrup form.
And I'm not sure if Dr. Rajat wants to further clarify his question if he's on the line.
The background is actually that for fear of temperature, this was one of the major reasons for barriers or for, rejecting immunization for Penta by the caregivers. So once they were told that it is a natural AEFI, then the child will develop some kind of a lower or medium level temperature after the Penta inoculation. And if you're giving Panadol syrup in 6 hours intervals, it will really help. So they were satisfied. And, this kind of information and communication really helped the caregivers because they already knew what is going to happen rather than, experiencing a child going through a high level of temperature and then not knowing what to do.
Great, thank you for that. And I think, Dr. Rajat, I didn't know if you wanted to add anything else. You had unmuted.
Thank you. I'm Dr. Rajat Garg from JSI India. And firstly, thank you for letting me the opportunity to ask the question. In India also, last year in 2020, the government of India, earlier they used to give the paracetamol tablet for managing this AEFI for the temperature and the fever. But from 2020, they got the guideline of paracetamol syrup. So definitely that has some effect in addressing the issue of AEFI. I have another question regarding the micro planning. Like, see, a lot of children are missed because maybe there are supply side issues. So can you elaborate a bit on that about how did you address that gap?
I think I will request Imran to explain that because he was involved in the micro planning.
Sure. The first thing which we did, we collaborated with District Department of Health and Immunization for including these slums in their micro plan to make sure that for them the antigens and all supply side items are available. And secondly, we, as Ms. Huma mentioned in her presentation, that we have had local community resource persons who were supposed to visit each of the community on daily basis for all the 26 working days we were working in a month. So in fact, those CRPs started the mobilization activity while doing micro census. Micro census is a kind of a detailed census where we register each and every child on monthly basis. So that intensity and frequency of micro census, in fact repeating it on a monthly basis, helped us to maintain the record of children who were in fact leaving the area, or in fact were newborn, or in fact were new entrants into the slums. So that micro census was a kind of best practice for us to make sure that no child in any of the slum is missed. And secondly, the community influential who were also organized in the form of a cluster health or community-based health organization having members from these slums. So those influential were also, in fact, guiding the local CRPs to register child if they were coming new to the slums we were working into. Thank you.
If I can add a few points in support of what Imran and Huma have shared. There were 4 factors to track and cover zero-dose children. Factor 1 was image analysis. We did GIS mapping of the Union Council to have exact number of slums that exist over a period of the project. And during the implementation, some of the slums were evacuated and new settlers came in. So factor 2 was a constant steering of evacuation, new settlers, migration processes, and newborn. And the third factor was micro-census, as Imran explained, that since local community resource persons were visiting on a daily basis to caregivers and identifying any new settlers entering the community, settling in, and then newborns being placed. The factor 4 was that we regularly were inputting to micro-planning processes at the basic health unit, which is the lowest administrative structure within the government system for setting up targets. So what we found out was that the micro-planning process had very conservative targets. When we provided them evidence from 3 sources, the Google source, GIS, second, micro-planning results, and 3, data from influentials and local resource persons, then there was no way to reject the data because this was not estimated number, this was actual number coming directly from the field and validated through the Google image analysis. Over.
Great, thank you for that. I think we've had a few more questions come in. So one, we have a question, where would this community access healthcare usually? Also, who were the leaders that you identified in the community? And this was noted since there was a migrant population. So this person indicated that it's hard to find leaders in that community.
I got question 2, but not question 1. I can respond to question 2 or Imran can respond to as well. Imran, please go ahead for question. Maybe if you can repeat the question so that Imran is able to comprehend and respond.
Sure. So the first part of the question was, where would this community access healthcare usually?
Okay, so community X, there was one basic health unit which was located at around 20 to 30 kilometers away from those urban slums. The distance varied for each of the slums. Some of the slums were closer, some of the slums were very distant. And none of the slums had any basic health unit or health facility available. So access was not very easy.
Great, thank you. And then the second part of the question was around identifying leaders in the community.
Yeah, sure. So we had 3-4 major types of influentials we identified to be part of health committee. Influential one was, there is a system that there are small informal contractors which give their land on rent for slum dwellers to install their temporary housing. so that government people do not evacuate them. They negotiate, the contractors negotiate with government through secondary means that they are allowed to stay there. Second, majority of the caregivers, either males or females, they used to work as a support, domestic support in different planned residential areas. So employers were also identified as one of the major factors to influence. And the third category were religious leaders, the spiritual leaders. There are some of the sects which used to have a strong belief on shrines, and they, in local language, we call it murshid, or the followers. So there were certain ethnic groups which have very strong belief on certain spiritual leaders. So those spiritual leaders were used as an influencing person. And the fourth category was role model caregivers who were used to influence their peers. So these are the four categories which were included in Slum Health Committee to work and mobilize zero dose and dropout children.
Yeah, one more thing, those slums were housed on the lands of some influential people. So the owner of that piece of land was also included as member of the health committees.
Great, thank you both for those answers. We've received a few questions just around the method that you use to calculate zero dose. Could you go into a little bit more detail about that?
Will you please repeat that?
Sure. So we had a couple questions come in about wanting to clarify the method that you use to calculate the zero dose children.
Yeah, as Ms. Lubna mentioned that we do microcensus to start immunization mobilization program in any of the activity. So that microcensus helps us identify children who have never been vaccinated for any of the antigens. So we fill in their profile and then in fact track them and include them in our mobilization program. So through our community resource persons and by using microcensus as one of the methodology, we identify and enlist zero dose children.
Great, thank you for that. I think we've addressed most of the questions that have been coming in so far, so feel free to share others again through the chat box, or you can also raise your hand. We just had a question come in from Laura, who is asking, were any other health interventions delivered along with the vaccines?
Did you ask a question? I could not get it.
Yes, so the question was, were any other health interventions delivered along with the vaccines?
Yes, it was in fact sessions which went hand in hand with this immunization program. As Ms. Huma mentioned in her presentation that healthy baby shows were organized in the communities to recognize efforts of the caregivers to ensure vaccination of their children. So immunization once in fact integrated into hygiene and sanitation in fact worked well. Similarly, that is one of the in fact aspect. And second aspect is that mother health, particularly for mothers of reproductive age, their inclusion into the program helps us to in fact to leave a kind of good impact. In fact, just doing things for immunization, if we compare it with. Thank you.
And in some of the cases, role model caregivers also helped a lot. to mobilize the caregivers who were a little lazy or lagging behind. When message comes from within the community with the same ethnic groups, with the same literacy levels, people speaking the same language, it helps to mobilize. So these were also very influential factors. The fourth factor was creating a scene of competition. When caregivers whose children completed immunization courses were recognized with gifts and prizes in a community settings, it really created a sort of competition. Okay, my neighbor's child has won the prize, so next time I would try and my child would also win the prize. So that's how a momentum was created in a constructive manner. Over.
Yeah, one more thing, that the microsenses, multi-pronged sort of microsenses. Like microsenses, on the one hand provides you information about status of immunization for the child. Secondly, also supporting factors like from where father comes in from, at what place mother works in. So that helped you to develop a kind of multi-pronged strategy for mobilization. Like what is their religion, or in fact where they go for their prayers. Religious leader was one of the fundamental determinant which we in fact used effectively while doing outreach activities, as religious leaders were coming on the forefront to inaugurate the outreach immunization activities. And because people believe in them, particularly in the from one of the province like Pathan tribe, so they really in fact are in fact boosted. They were boosted once their in fact religious leader inaugurated and participated in the immunization associated activities. Thank you.
Great. And I think Huma, you have your hand raised.
Yeah, I just wanted to add one of the major significant, the turning point was actually the selection and the work of community health worker, community resource persons. These were young girls, from the community. They were young, they were motivated, and with their great interpersonal communication skills, they took on themselves, to do convincing and to make sure that no matter how rigid the refusers or the families of the caregiver or the caregivers are, they will make sure that they agree on immunization and get the child fully immunized at the end of the session. If it was not done at the end of the session, they would repeat it. They would go and visit their houses again and again. And since these were, young girls from the same community, their acceptability was not as difficult as it is in other areas that we have worked. So I believe this is a cohort that we really need to invest in. Young girls can really play a very important role. First of all, they are committed. And once you give them the responsibility and with good interpersonal communication skills, they can really do this job very well of convincing the community, because it was not easy. There were repeated visits of the houses, and as compared to male, of course, who cannot enter their houses in the setups of the cultural and the religious context that we are talking about, it was easier for these girls because they were from the neighborhood, they were from the same community. So it really matters for people who really want to work in the area, or if they want to take away from this project. Thank you.
Wonderful. Thanks so much for that additional context. So I know you've talked a lot about the various stakeholders that you've engaged in this program, but could you share a little bit more about how, or if you used communication channels such as media, social media, posters, flyers, radio in your program, and which one of those methods you found most effective in mobilizing your effort? And are there any lessons that can be replicated in other country settings?
Yeah, we used, in fact, the local community source persons and provided them information, education, and communication kits, in fact, designed particularly for mobilizing mothers, and in fact, helping them to clarify their myths regarding immunization, and developing, in fact, their understanding around total immunization program. In fact, just one vaccine or two vaccines are not sufficient. So in-person communication using charts and IEC material was more effective. Otherwise, we also, in fact, use local cable operators to disseminate the timings of the outreach activities, and about the establishment of temporary kit stations, in fact, established particularly to cover zero-dose children residing in these slums. That was also used. But then in our context, you see that masjid is mosque is very a kind of center point for any of the community. So during Friday sermons and Friday prayers sermons, the religious leader and his seat and his mic was used to disseminate public service messages, in fact, regarding benefits of the immunization. Most effective one was the interpersonal communication held between the caregivers and local CRPs, because that help you to take their questions and in fact respond to their myths and biases or whatsoever they have got in their mind regarding immunization. Thank you.
Great, thank you. We did get an additional question about if there are any publications or reports for this initiative. We obviously have the Bright Spot story write-up, which is available on the Bright Spots microsite. But are there other kind of materials or reports or information that are public and that could be accessed by others?
I cannot, in fact, get, please come again, because there is some disruption in the voice.
Sure, no worries. So we had a question around if there are any other publications or reports for this initiative.
Yes, as we were partnering with the UNICEF and then provincial EPI of Punjab and then district EPI department of Lahore. So progress report for this very project as one of the article in the agreement exists, but this is first ever public dissemination of this case story from 12 urban slums of Lahore. I don't think so that another publication for similar, in fact, context and similar program exists at the moment.
We must thank the Boost team for, taking it up so well, I think.
Wonderful, thanks so much. Well, I think we have reached the end of our questions, unless there are any more. So I just wanted to thank you all for sharing your insights and lessons learned. Obviously, the story, as I said before, exists on our microsite. It can certainly continue the conversation on the Boost community platform. So I just wanted to share a few additional steps. So MJ, if you could go to the next slide. And also just wanted to share, we also have another initiative called Sparks, which is similar to Bright Spots, but it really captures the real-time moments of innovation or overcoming challenges. So looking at individuals' efforts and highlighting unique or impactful solutions during a pivotal moment that aims to increase equitable vaccine access in communities all over the world. So this might be a quick lesson learned from a project that you're just recently implementing. You might not have results yet, but you have some key lessons learned that you'd like to share out with our community. So you can visit or you can submit your Spark through our Typeform application, and we'll work with you to share out the lesson learned in a quick 5 to 10 minute video. And I think my colleagues have shared some more information in the chat box if you're interested. Next slide. Again, encourage you all to join us on the Boost community platform. It's free to set up your account and should only take about a few minutes of your time. That way you can access today's recording and slides and any other resources that we have on the platform. You can also join our new Telegram channel, where we send out reminders for our live events and registration for upcoming courses. So definitely check that out. It's not, we try to not send out too many messages, but just alert you when we have some of those events that are coming up. We've also created a dedicated Bright Spots learning group on the Boost platform so that you can actually have some more additional conversations about the bright spot that you heard today and others that we've been releasing over the last several weeks. And just a reminder to please take our post-session survey. We always want to be responsive to your feedback and design these sessions so that they're as most useful as they can be to you. Next slide. Great. Well, with that, I just want to again thank all of our presenters today for sharing their story and answering all the questions from the community, and just thank you to all the participants for your excellent questions and engagement throughout the session. Have a wonderful day, everyone. Goodbye.
Thank you so much, Boost team. Thank you so much for giving this opportunity.
Goodbye.
It was really a very learning session, and we were able to share some of the initiative that we did.